it takes me immense pleasure that this is going to be something which is at the bottom of my heart, and that's the musculoskeletal ultrasound session. So it takes me immense pleasure to invite my chairperson, Dr. Sridevi Suresh from Thiruvananthapuram to take the dais, please. So we are all aware of how useful the ultrasound is, and some of you have attended the session by Ingrid ma'am as a pre-conference workshop, and we all learned how beautiful the ultrasound is under that scanner, how useful it is to pick up those pathologies which clinical examination can't. And also, it is extremely important tool when we are in doubt regarding any joint region pain. For me, the biggest utility of ultrasound is to differentiate a region, periarticular pain, from the articular pain, and also it can be used to detect remission, to detect subclinical inflammation in the joints, and we probably can reach stage where we can use it for defining the remission also. So without taking much of your time, I'll call upon Dr. Cheng Kong from Singapore to take the session forward.
Thank you, Mr. Chairman, and good evening, ladies and gentlemen. Good that you stayed until the bitter end before the gala dinner. I'm going to make sure I make this interesting for you. And before I start, I want to really thank the organizer, especially Professor Danda, for the kind invitation to the Iracon 2022. Really good to see everyone, especially in person, after 3 years of COVID, not just staring at the screen and speaking into a computer. Let me just set this up first. Okay, so before I start, have a show of hands. Who does ultrasound here? Of course, other than Professor Ingrid. Everyone? Not everyone. Okay, so I was tasked by Professor Danda to speak on the assessment of remission in RA, ultrasound versus conventional tools. I've been doing ultrasound for 20 years, so I believe in ultrasound. Of course, some of the data that I'm going to walk you through might be a bit uncomfortable for those people that are very enthusiastic about ultrasound, but I think we need to know the limitation. And in the next very short 15 minutes, I will first attempt to highlight the differences in the different conventional tools in assessing remission and RA activity. I'm going to walk you through the landmark and conflicting studies in the use of ultrasound in assessing remission, and share with you some of my own personal perspective of these studies and what questions we need to ask ourselves, having done ultrasound at the bedside for the past 20 years. So this is what I've learned, the pyramid of treatment in medical school. But of course, we know that fast forward 20 years later, that this is incorrect, as early diagnosis and treatment leads to a better outcome. And thanks to the armamentarium of drugs available, we as rheumatologists can now not only recognize but seize this window of opportunity. And in addition to the conventional synthetic DMARDs like the good old methotrexate that has been used since the late 1970s, we now have the different biologics, and now we have the targeted synthetic DMARDs, which is the kinase inhibitor. Not only do we have better drugs, we also know from the Ticora study that intensive DMARD therapy improved disease activity in RA in 2004. And subsequently, you have two more studies, the Camera and the Frenzen et al. Study, which again proved that tight monitoring improved outcome in RA. That led to the formulation of the concept of treat to target in RA by Professor Smolin. And I would just like to highlight the last bullet point where he said treatment to target by measuring disease activity and adjusting therapy accordingly optimizes outcome in RA. So what are the instruments of measurement of RA disease activity? this informed audience would be very familiar with this table, and I suppose the last three would be important. These are the clinical disease activity index, the DAS28, and the SDI. Do note that the CDI has a maximum point of 26, while DAS28 has 9.4 and SDI 86. And this is a formula. Essentially, SDI and CDI are the same, except that in SDI there's a CRP, whereas CDI, a clinical disease activity index, there is no CRP. And the DAS28 is this little formula that you can calculate, or you can just plug into any online app and it'll give you the data. This is the old ACR criteria for remission, and now we know that there's a new ACR EULA recommendation for remission. There are two things that will define the patient being in remission: the bullet-based definition, very similar to the 1981 criteria, except that the ESR has been replaced by CRP, or the index-based definition using SDI of a score of 3.3. You would note that in September this year, just 2 months ago, ACR has updated the bullet-based definition, and they have used PGA to be less than or equals to 0.2 because they found that this is actually more correlating better with the SDI. I spoke about the instrument of measuring activity. I highlighted the underlying formula. I talked about the ACR criteria, of ACR EULA criteria of remission. But I'm just going to highlight this study. And what I want to point to you, ladies and gentlemen, is that DAS28 remission in this group was 17.5. Depending on what criteria you use, you have a different proportion of remission. If you use ACR EULA bullet remission, it will be less than 20%. So it is important that all of us remember this, and of late there's a lot of criticism about DAS28 as not being an ideal instrument, although it's being used in clinical practice, including myself, as patients can still have a symptomatic joint and yet receiving a score of less than 2.6, which is equivalent to remission. And certain drugs like the JAK kinase and the tocilizumab reduce CRP and ESR disproportionately, even though patients can still have clinical signs and symptoms. You recall this in 2006 and 2008, Brown et al. From Paul Emery's group published these two very, I would say, alarming finding that MRI and ultrasound detected synovitis in the majority of patients in clinical remission. And in patients with clinical remission, 2 years later, it says that all these predicted subsequent erosive progression on conventional radiography. Right? Then we have the TASER trial done by James Dale, and then we had the Arctic trial, which said completely the opposite. What happened? Why did this happen? I'm going to just walk you through this landmark study in 2006, where they found that 73% of the patients, so what they did was that they had 107 RA patients deemed to be on remission by their consultant rheumatologist and 70 normal control. And guess what? I just want to highlight one thing. They were deemed to be in remission by the consultant rheumatologist, but if you look at the number, the ACR remission number of the percentage was only 55%, and the DAS28 disease activity, the remission was only 57%. Nearly half of these patients were not in remission, even though the consultant rheumatologist said that. So I think it highlights the importance of using instruments to measure disease activity. What he did was that other than collecting clinical and laboratory data, they did the MRI, and Dr. A.K. Brown, regardless of patient symptoms, was a sole sonographer who scanned their dominant joints covering 8 regions, from 2nd to the 5th MCP, the wrist, and he was blinded to the clinical finding. I think this formed the basis of a lot of the studies that I'm going to walk you through and how they scanned the patient. So what did they find? They found that even in asymptomatic patients with clinically normal joints, MRI showed 96% synovitis and ultrasound 73%, and it will increase Doppler signal in 43%. How did they interpret? How did Paul Emery and his group interpret it? they felt that this subclinical inflammation may explain the observed discrepancy, and they suggested that imaging assessment may be necessary for accurate evaluation of the disease status, and in particular for the definition of the true remission. That started the 2E movement, which I was part of it as well, and we have met many times, including Professor Ingrid. Okay, where did they get this? So what they did is actually, if you look at the paper, there's no time for that, table 5. And they separated the patients, those with 0 joint pain and those with more than 0 joint pain. And you see that we're using this criteria, the ACR remission number in those with 0 joint pain was 93.5, or the N equals to 29. And the authors felt that this synovial swelling was actually significant, that this swelling was clinically relevant. So again, this is by the DAS28 criteria, but the MRI as well. You know that, but if you look at this number, there was no difference between the group, whether is it MRI, whether is it ultrasound, but they felt that this was clinically relevant. But I think one key point, if you dig into the detail, is that out of these 354 joints with synovial hypertrophy, guess what? 82% were just graded as mild, probably a OMERAC 1 or maybe less than 1. Okay? And looking at the data another way, where patient is stratified into various disease activity index, you can see here remission, low, moderate, high. There was no difference. Whether you're in remission or whether or not you're high, they all had the same prevalence of synovial thickening. And this tells me that mild synovial hypertrophy is probably a serological scar, or it's syphilis, or it's a synovial scar. It is unlikely to be of any clinical significance. But unfortunately, this set us on a wild goose chase, all right? And if you look at this is a wonderful study that has been done in MTP joints in RA. These findings are not specific to RA patients. In 20 healthy individuals, 2 showed erosion-like changes, 12 showed signs of inflammation on MRI, and 10 on ultrasound. And furthermore, in healthy individuals as well, this is old data that's been published, you see the same finding. And what's a normal MRI? The same question that many people working in SPA are realizing. Having bone marrow edema, having erosion does not equate spondyloarthritis, all right? So this is the same. In OA as well, you see that. Therefore, ladies and gentlemen, in my clinical practice, I think I do not just intensify therapy because I detect synovial thickening on MSK ultrasound. You have to grade that, you have to correlate it clinically. Then this is a follow-up study, same study design, 100 patients again, and while I put less weight on synovial thickening, I must agree that I put more weight on the Doppler signal based on this same study. So in this study, they found that 19% of the patients had displayed deterioration. There was no change of treatment. They did it at baseline because they were deemed to be in clinical remission. It is not unethical. It is not unethical to change the therapy. They follow up them 1 year later. 20% had progression. All right. So again, note, clinical rheumatologists define remission. There's only 57 of these patients were again in DAS28 remission. Okay, but if you look at the statistical significance, it was between the no radiographic progression and radiographic progression, you do see that there is a statistical difference. But other than this difference, yes, it is statistically significant, but is it clinically relevant? What was the median joint score? Well, in the 2006 study, it was 6.5, and in 2008, it was only 2.1 change in the sharp score. What does this tell you, right? So I will come to that later. And importantly, you must see this is a cohort of your patient. You will notice that 80% of the patient had no radiographic progression. It's only 20%. Of course, if you are more symptomatic, you progress more. If you are less symptomatic, you progress less. So these are the two curves. And it's similar to many of the drug trials that we have seen. Basically, only 20% of the patients have radiographic progression. which means to say that mean total sharp score means nothing nothing at all. And giving you a sense of perspective, what is the maximum score? You can see here a total score of joint space 422, 448, 290. And in this very old study that was done, an MCID and an SDD is actually 5 sharps unit. And you would know in the literature that rapid radiographic progression, which occurs in about 20% of the patients in all drug trials, is defined as 10 sharp score. So these are important things. Are we talking about clinically meaningful changes? So, ladies and gentlemen, to me, it is not a surprise that the taser did not show any change in the MRI erosions for the reasons that I have alluded to earlier. What was the taser trial? When I remembered when James Dale presented this at the ULA meeting, there were a lot of angry questions. I remember that distinctly. What he did was that he single-handedly actually scanned all these patients, one, either RA or undifferentiated arthritis. They had this weird protocol, which I do not know why. He didn't scan everyone. He only scans if the DAS28 was more than 3.2 and with less 2 swollen joints, or when DAS28 was less than 3.2. But he was, I think he was very good in the sense that he was the only person using the same machine, using the same setting. I'm sure at the MSK ultrasound workshop, settings are very important. Your frequency, your PRF, your wall filter, this affects the thing, all right? But the only thing is I do not know the timing. When did this patient have it done? And he believes that active disease was defined more by PD than by any synovial swelling, and therefore he defined it as a presence of PD in any 2 joints. So this unlike the Brown study, based on the MRI and the clinical disease activity, they escalated the treatment. Very strict protocol-driven control like that of the camera and the Tigora study. But there was no difference whether or not is it clinical, whether is it not erosions. So this is a table that I showed, whether it's clinical or radiology, it's the same. In the interest of time, I'm not going to go through all the details. This is from the Scandinavian country, the Arctic trial, similar design again, all right, but the key difference is that it is 11 centers in the Arctic trial versus 3 centers in the TASER trial. There were 238 patients versus 100. The Arctic trials used the ACR unit 2010 criteria, whereas Dale used ACR and undifferentiated arthritis. 2 years of disease duration versus 1 year, 24 months of follow-up versus 18 months. And similarly, they change it based on the either if you are randomized to ultrasound, there's a 10% change, and then they will adjust the thing. But I think there is one key difference, which is a concept of standardization that I want to introduce. In the TASER trial, they scan 18 joints. These are routine, blinded, whereas in the Arctic trial, they scan 32 joints. Do note that all the patients that were scanned, different machines were being used. The timing of the scan is unknown. Although they went for some training course and ULA course, I searched through the article. I do not think that they did, all these sonographers did a study to show their inter-observer variability. I think that's the key point. And that comes to the point of the standardization. We know the OMERAT definition, very loose definition. This is grade 0, this is grade 1. But you see, this is grade 2. And this is grade 2 as well. So there are a lot of variability. This is a semi-quantitative, it's not rocket science. Of course, this is grade 3. And so in our experience, we are all trained. Dr. Kong trained at Leeds, and then he came back and he trained all of us. We did this and to see whether or not what is the intervariability. In the interest of time, we did what the Arctic investigator did. We went through static pictures, we had real-time scan, and what we found was that despite all this training, it was useful in improving inter-observer variation in synovial scoring by ultrasound, but agreement in the non-hand joint, it is still a problem. Right, so this is the last point that I want to bring up. And I'd like to conclude that, yes, there may be no role in routine, non-clinically directed in monitoring, but in diagnosis, in therapeutic, I do all my injection-guided when I'm not sure whether or not is this as what the chairman has said, is this articular or is it periarticular? Sometimes a lot of fat, you can't tell. So these are still very, very useful. Clinically directed. In tapering, sometimes I'm not sure, I taper, I put on the Doppler, I use the same setting, and then I compare again after I taper my medication. I say, oh my gosh, the Doppler has come out, and I know that we may have problems. Maybe in pre-RA to predict. There are some studies, there's no time for me to go through all this. And so I'd like to conclude, ladies and gentlemen, that actually early diagnosis, early treatment is key to the good outcome in RA. Close monitoring, tight control is important. Be aware of the limitations and the performance of the various conventional tools which I've highlighted, whether you are using S-dye, C-dye, DES28CRP in defining remission. I don't think routine monitoring to assess control and remission in RA has not proven to be superior than conventional tools. But is there no role? I don't think so. I think clinically directed ultrasound examination is and will continue to be a useful tool, although research are still needed to prove it. And I really, really hope that research is being done to determine what is clinically significant synovial signaling and Doppler signal that will change the clinical outcome of the patient. Not a sharp score of 2 or 3 spread over many joints, but a clinically relevant one. And I'm still a firm believer of ultrasound, and I just want to let you know that ultrasound is really a very useful tool, and there are many other roles of ultrasound examination. And with that, I thank you.
Very insightful talk by Dr. Sheng. The session is open for discussion. Any question and answer on this session?
And in all the points that you were developing during the speech, I think that probably our main issue is the reliability. And even we're supposed to be a group of experts. Our kappa is 0.6,
Yes.
0.7. So I fully agree with you. That was just a comment.
Thank you, thank you. I was afraid you made me angry. I had many, when I had this discussion, I had many angry responses.
Dr. Sheng, thank you for an excellent talk. I'm Suresh Adimalam from Vizag. I've also been doing ultrasound in routine practice for the last 10, 12 years. And we do come across a lot of subclinical synovitis and power Doppler signal in patients who are not that clinically aggressive disease. So after listening to your talk, I'm actually more confused about what to do with them. Previously, I used to think that, okay, they've got subclinical disease and start them on DMARDs. The clear-cut definition of active disease, clinically active disease, grade 3 power Doppler signal, you go very aggressively. Those who the clinical disease is not that active, but they've got aggressive disease on ultrasound.
So the overarching principle is a discussion with the patient, the treat to target, because it's not what I want, it is what the patient wants as well. And if it's a grade, there's a different grade 2. As I showed you the picture, right? The former grade 2 might be different, and the later grade 2 may have a different implication. So I am thinking that the future may be AI, maybe a 3D scanning, that you can quantitate the Doppler. And importantly as well, the amount of gel you use, the temperature of the room, and the timing that you do them. If you one day you do it in the morning, right, and the other day your aircon is so cold, and you do it in the afternoon after they have taken the prednisolone or whatever medication, the results will be very different. The results will be actually very, very different. So it's a discussion, and we can always monitor, right, unless it's a very rapidly progression. But as you know, the study has told us 80% of them don't progress. The drug rep will tell you that there's radiographic progression, but when you ask them what is the scale, 2 points, 3 points out of 400 points, right? So it's very different. And of course, but if it's a single joint, 5 points progression in a single joint means a destruction of the joint. And of course, it depends on what joint it is. Is it a very critical joint? Is he a pianist? Is he a professional violinist? So these are all the factors that I would consider, and not just based on whether or not is it a grade 3 Doppler, or whether is it a 2+, 2-, or the synovia is grade 3 or grade 2. Because I have some old aunties that have very swollen joints, but they say I'm happy. I'm not going to do push-up or pull-up. Yeah, so it's like interpreting an A&A results. Yeah.
Thank you.
Thank you.
Sir, before you leave the podium, I just have one question to ask. That taser and optic trial both were negative, but they were including very early rheumatoid patients and targeting a power Doppler of 0, I think, in the joints examined. So those are the patients where drugs anyway work. So do you think it was the wrong set of patients?
Well, it's difficult. The original Brown study was 2006, where biologics was just made available. And by the time they did the trial in the early 2010s, the treatment has changed. So to recruit all patients, it might also be difficult. But again, I agree with you. It's like the lupus nephritis trial. Your drug is so good that it's difficult to prove difference between either
baseline drugs.
Yeah. So, and the drugs are better. We have more options.
Yes.
Thank you.
Undifferentiated arthritis, which involves risk. So, rheumatoid arthritis is more common to involve risk, and the patient has a seropositive, rheumatoid factors anti-CCP negative, but he has synovitis and multiple erosions. But MRI-wise, they have reported it as possibly tuberculosis. So, is there any way out to differentiate between tuberculous erosions and rheumatoid arthritis erosions?
Okay, so you're thinking about a TB joint, then I would do an ultrasound-guided parts biopsy of the synovium. Yeah, which you can do it in the clinic.
Ultrasound-wise, there are no differentiation.
I don't think you can tell so much. I think Professor Ingrid, I find it more useful to differentiate RA versus SPA based on certain features on the ultrasound. The infection-wise, sometimes what I will do if I do not want to do a biopsy or the patient doesn't want me to do a biopsy is that I will just give a course of steroids. Not injection, but oral steroids. If it's an inflammatory arthritis, typically it will go away. If it's actually a septic arthritis, you bring the patient back and scan, you will still see the Doppler that is super big and screaming at you, on your face. So this is something that I will do clinically. Patients do not want a biopsy. If you look at James Dale's study, the baseline cohort in the control and intervention arm, 70% had positive rheumatoid factor and anti-CCP. I think it's about the same in the Arctic and TASER trial as well. Not everybody had a positive rheumatoid and anti-CCP. Yeah.
Thank you.
Thank you.
Thank you, sir. Thank you. So ultrasound guided therapy in spondyloarthritis and psoriatic arthritis.
This is my first time in India, so I'm really, really happy for this invitation. And I am also happy to speak about something that ultrasound has a role, a very clear role, that is guide therapy. And the question, when they asked me to explain something about guide therapy in spondyloarthropathy and in psoriatic arthritis, to me was kind of shocking topic, because I was thinking what I can explain. But maybe we have a lot of questions when we want to do some interventionism. So why we do following with the treat to target when we face this patient who has signs and symptoms, maybe only in one joint, and we want to have a solution, or we want to study a potential solution, whatever is arthritis, tenosynovitis, bursitis, even any peripheral enthesitis, we can try with some interventional procedure. So for that, ultrasound, it's really awesome. And we feel really confident when we see our needle going inside the joint and knowing that we are exactly in the place that we want to stay. When? Well, we know that this early intervention delays and suppresses the peripheral disease progression. So my point will be, if there is one localization or there is really few locations for inflammatory signs, for tenosynovitis or arthritis, probably I will try, besides the treatment that you are giving to your patient, but I try to do some guide procedure. And I can do obviously even more when I see a huge Doppler signal, because to me it means activity. Even we have the problems of reliability, and even what is the main point for me, and has been all my life, is that we need to know perfectly the anatomy and the son anatomy of what we are examining in order to avoid problems with anisotropies or with any other image that can be difficult to understand. Then we have differential diagnosis. Our patient has pain and has psoriatic arthritis, but maybe the pain is coming from this image. This image that is, as you can see, this is a total rupture of supraspinatus with some bursitis beside. Bursitis that you can see here in the short axis view of the bicipital tendon. So here we have another example. This patient came with this synovitis that is not so big, although you see the content is some synovial hypertrophy, but what caught my attention was this enthesitis that in fact was compared with the other side, and this is the reason for the pain in that particular knee joint. So we need to really examine the patient and we need to see what is happening, and we don't give the same treatment obviously to shoulder with a rotator cuff pain, even if it's an inflammatory patient and we don't want to increase the corticosteroids for that. We have, on the other hand, we have pathologies that can be very well studied by ultrasound, and in our case, combining that with anatomy. Say this is the case of paratendonitis. Now, I am particularly involved in the study of the polyenthesitis or the dactylitis that we'll see if it's appropriate to call that polyenthesitis. And you can see in this image the connection between capsule and extensor tendon and what happened when we inject our specimen, and you can see how the injection comes from the joint to the paratendon. So we want to see in the future if the concept can change or not. Why we want to do sonographic guidance? And I go to an old paper, old article, and you see that there are many different aspects to consider. But probably to me, the main one is the patient. Ask your patient, would you want me to do a blind injection, or maybe you prefer me to use the machine? I don't mind. I can do in both ways. I am doing that for 40 years, so I am a clinician. The patient always say, please use the machine. So probably this is why I use the sonographic guidance. And with sonographic guidance, always I do hip joint. Although maybe you can say, well, but I can do also blind. Yes, but I feel much more confident if the patient has a synovitis at the hip joint. I will use the ultrasound. How? For those of you who are not doing the ultrasound, probably is not so interesting, but we calculate many things that we can calculate with the ultrasound machine, like the angle, the depth, the thickness of the needles or the gauge that we use in any case. And for us, the interesting aspect is when the needle enters the skin parallel to the probe, something that is not always possible, or when we are doing spinal procedures, sometimes we can do parallel, sometimes we do more or less parallel. Obviously, we avoid neurovascular structures, and something very relevant, but not always done, is you need to look at the patient, not at the machine when you are introducing the needle, because the probe is your guidance. So if you don't see the probe, you don't see the needle direction. That was an example of a guide injection of procedure that can be applicable to many different pathologies, maybe not only psoriatic arthritis, but or spondylitis, but even a patient with osteoarthritis or CPPD disease. And you see that in that case, using a specimen, this is a cadaver, this is not a real person, because you see that we use the gloves, but we don't use any kind of a sterile gel or anything. But this is the way that we train our fellows and even the medical students in how to do a procedure. And we try to encourage them to do it with guidance. So in big joints, large joints, such as the hip or the shoulder, we use this spinal needle. Always we use a spinal needle, also in lumbar spine or sacroiliac joint. And we do the injection, as I was telling you, we do this with guidance. And you can see here the guide injection to the hip joint. I hope it is, yes, it is well seen in the screen. We do also injections in the sacroiliac joint, but not with the purpose of treat sacroiliitis. It's mostly for confirmation of the diagnosis. And it's also because in some patients, maybe the problem is not the synovitis itself, maybe the problem is mainly around the ligaments. So the literature told us that these injections will be useful 2-3 weeks, but maybe not for a long time. We were explaining years ago how to obtain an image, an ultrasound image of the sacroiliac joint. We also do, and any person with ultrasound machine sure do the same. We do injections around the tendons, which have tendon sheath, and this is a case for the flexor tendon of the finger. And you see that we want to inject around the tendon within the tendon sheath, but we don't want to inject within the tendon. And this is why we can use also ultrasound guidance, and that can be a solution even in patients with psoriasis that you know that they have these thicker pulleys. We can try to do some procedure trying to make the pulley or the space a little bit bigger for them. What we need is what I say at the beginning. We need the anatomical knowledge, and I am really, really strong in that point. We need to know where we place our needle, and we need to know what is happening in the structures that we want to inject, because we need to know if there is an inflammatory process or if there is any other event that is happening in the joint. Those of you who were in the course were seeing the images from the subacromial subdeltoid bursa, like just showing you what we do and what we can see. So if we see the bursa, we can see perfectly by ultrasound. We know that we can inject around the bursa, we can distend the bursa. and we can, in that case, was to show how big is the bursa, but now in the case of a patient, obviously will be to have a treatment for bursitis. Very important and very relevant for both, for biopsy or for injection, is the knowledge, again, of the anatomy around the MCP joint that is really relevant for us, and to calculate where we want to do an injection in cases like this one. This is a peroneal tendon, so probably you don't want to choose a retromalleolar place to put your needle because it will be much more difficult. So you can move a little bit more proximal, and you will try to avoid the sural nerve or any other neurovascular structure located there. Lateral bursas around the hip joint can be an inflammatory manifestation in our patients, and this is the real trochanteric bursa. You know that we have more than 20 bursas around the trochanteric area, but the real trochanteric one is in between the gluteus maximus and the iliotibial tract band. Here you see it, and here you see a procedure in a patient where we can do the injection, and we can say, oh, we are very happy because we have this reduction of pain that is really high, 75% at the week number 4. But you can see that after 3 months, the thing is not so good. And really, when we consider the patient in the whole context, meaning patient with knee OA or back pain or any other issue that is besides the bursitis, we need to do much more things. So the injection is one particular solution, but it's not the whole solution for our patient. Dosage and risk is probably not something to discuss here, but you see that we can have sometimes, we can have problems with our patients. And I put here the recommendations of the Canadian Association of Radiology that you can see and you can read. They are free in the website, so you can read the article and you can see the different dose that they recommend, that I was really agree with them. And the volume, there is more or less a kind of rule that equal or less than 0.5 milliliters if you are in a small joint, and then you increase the amount depending on the joint that you have, a middle size or large joint. I was considering this article because I think it's interesting to know what happened with our injections during the pandemic. It looks like it was not bad, because the study, but it has limitations, but the study tells us that the symptomatic infection was lower than the general population, and it looks like the injections that during this period, I think all of us were kind of scary to do it, were not so bad. Remember that our surgeon doesn't want we to do an injection before arthroplasty, and this is controversial. You will find articles saying yes, you will find others saying no, but in any case, we don't need to do exactly 3 months before, so if we can avoid that, probably will be much better for our patient. That is the last slide that this was recently published by our group as new recommendations for in particular therapies. Let's say that probably is nothing new for you. What we were doing is review of the literature, and we realized that there are really very, very short literature regarding some topics when we are doing in particular therapies. So thank you very much. That was all regarding these interventional procedures in spondyloarthropathies and psoriatic arthritis.
Thank you very much.
Thank you, madam. Thank you, Doc. Now the second session is open for discussion. Any questions from the audience?
Thank you very much. I do not do ultrasound, but I was just curious about the Achilles tendon. What is your experience with it using the ultrasound for injections in the pre or post bursitis or with tendonitis? I'm actually very afraid to give a shot of steroid in the area, which is why I asked the question. Thank you.
Thank you very much. Very nice question. We use when there is a bursitis, and it's an active bursitis, not only in patients with psoriatic arthritis, but gout, rheumatoid arthritis, in the retrocalcaneal bursa. And we have a very nice access that we do from medial to lateral, because what we always want is where is the enemy. The enemy is always the neurovascular bundle. So we want to see the enemy. Once we see the enemy, we go in a posterior way through the Caher-Fat path and we reach the bursa without problem. We don't inject tendons. We don't do PRP. I am not so believer in the PRP, although the sports medicine, my colleagues from sports medicine, and they are very strong in Barcelona, they use a lot and they are very happy. So let's see, maybe they are right. I am not sure. But sometimes, if the patient has a huge paratendonitis, I consider the possibility. I am not fan of, because I see many patients that were receiving injections, particularly in the tibialis posterior tendon, that then they develop a tear. So not at the Achilles tendon, but tibialis posterior. So I'm not a fan of repeat and repeat injection. Once is okay. If it's right, it's okay. If not, let's use any other therapy, because I am speaking about corticosteroids. There is a technique that is used by colleagues from Japan that I think it's fantastic. They use mostly for the spinal problems, but they also apply in some other peripheral areas. That is just, they inject just saline, and they obtain very good results. So there are not so many articles explaining about, but I was working with them and I was thinking, well, let's see, because that looks very interesting and very safe for patient and for us also.
Thank you.
Thank you for the.